Assalamu alaikum. Welcome everyone on board. Safiullah, can you tell me what are the reasons for failure of weaning? We are doing this ICU review. So today we will just try to cover this topic of weaning and the failure of weaning, and then we will go towards the muscle weakness. So yes, Safiullah, are you with me? Anyone, please? Sundas, do you want to answer?
Failure of weaning has many causes.
Okay.
There may be reduced muscle power, nutritional deficiency, and
What
और
else?
क्या होता है, prolonged ventilatory support. After prolonged ventilatory support, it will be difficult for the patient to wean off prolonged
Okay.
intubation.
Okay.
And mm, other one is a metabolic disorder, maybe having sedation for a long time.
The Yes. So first thing
Uh,
you can say for first thing that the patient was not ready for weaning. Okay. And you
yes,
tried
yes,
in early. Okay.
yes. So कोई
So
सारे drug effects हो सकते हैं, metabolic effects, electrolyte imbalances
yes.
वगैरह. First we have to rule it out, and then we will proceed for weaning.
Okay. So there is a mnemonic here out written here. Uh, Weans not mnemonic to aid clinicians in identifying such issues which can lead to failure. Okay. So V's, especially COPD, asthma, heart disease, and fluid overload, electrolyte and metabolic derangement, anxiety and delirium, neuromuscular disease and weakness, sepsis, nutritional insufficiency, opiates and other sedatives, thyroid disease, and you can just think about it. For example, we can just explore with this. What will be the effect if there is V's or COPD?
Hypoxia, brain
Very good.
hypoxia हो सकता है.
Okay.
और
What else?
um, bronchospasm,
Yes. O-
pneumothorax,
Yes.
and
Like just like a baby, the
hypercapnia.
the same thing which is called as weaning when the baby are coming from the mother feed to or the bottle feed to solids. So if you just immediately try to put a lot of burden, he
Mm,
will not be able to tolerate. So same theory, that's why the word is there. So if you go one by one, if the patient is in overload, again, when
mm,
the load will come of patient, right now you have relaxed the body, you are ventilating by himself, by yourself. Now
mm,
the body has to fight against the resistance. So what of breathing is there? So everything is putting load on the cardiovascular system and respiratory system. Okay. Then electrolyte. Think
mm.
about electrolyte. What electrolyte and metabolic problem will cause delayed in weaning?
Magnesium phosphate,
Okay, very good.
magnesium
Phosphate.
phosphate.
Why? Do you know why? Why can you just tell if someone asks you what's the significance of phosphate?
Mm, muscular activity may be involved in
Muscular activity or something
respect
else? For our energy,
for
what we need?
ATP.
Very good. So adenosine triphosphate. So it is
Yes,
the
yes.
the 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 supply line. Okay. So if phosphate
Mm,
deficiency is there, all the metabolic problem, metabolic things will slow down. Okay.
mm,
So that is the major reason for the failure of weaning. Okay.
mm.
So and what about what will be the effect of sodium?
Sodium.
Yes, please.
Mm,
Think sodium. What like sodium has effect on which system? the 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 brain
This
vasculature and
has
brain.
effect on CNS. There will be delayed awakening.
Sorry,
Mm.
delayed what?
Awakening will be delayed.
Sir,
How?
CNS had effect on CNS actually.
How?
Uh,
How?
like if there is hyponatremia, it causes the brain edema occur, headache, confusion. It depends upon its
The
mild or
sodium,
moderate or severe
the
hypotension.
sodium level will make sure that the
So,
patient's intravascular and extravascular volume is maintained. Okay. If sodium
yeah,
level is disturbed, it has significant effect on the cerebral physiology. Okay. So that will be a cause, like there will be either cerebral edema or pontine myelinolysis, as our Fahad has written. So that is a, so if the neurons will slow down, all the it's like grandfather. The grandfather is not working, so everyone will be slowed down. So that's like it. Okay. Nutrition. What will be the effect on nutrition on weaning?
Protein play an important role for muscle power.
Hmm. So if the
Protein
albumin, there is
and
albumin deficiency or
albumin.
vital vitamins deficiency, so it will lead
Yes,
to.
anemia.
So similarly, thyroid disease. Thyroid is also like the powerhouse. It is controlling
Mm.
the cellular
Various
metabolism.
metabolic function.
So that
Mm.
is a problem. And then come to the opiates. You have given a lot of sedatives, midazolam, because
Mm.
usually, like even if we are using fentanyl, initially fentanyl is miskin. Fentanyl is going out of the circulation. And I used to say by fun, it's like anesthesia technologists, anesthesia technicians. They have they have some repulsive power to go out of the operation theater. So they are like that. So, but what happens gradually, when it is going for hours to days to weeks, then fentanyl has overwhelmed the fat reservoirs, and now the elimination half-life is equal to morphine. So that's why if you want to you are planning the patient to be weaned off, it's better to convert to a thing which does not depress respiration. Like what is the medication which you can use for sedation? In that case, even midazolam will have long elimination half-life. What will be the medication which will have less effect on the respiratory system?
next
Presidex.
machine.
Yes, Presidex, dexmedetomidine. Okay, so dexmedetomidine will be a better choice in that way. If the sepsis markers are there, then again it's sort of a negative stress on the body. So these are the things. Now we think that how to wean the patient. So usually what happened, that gradual, if the patient is on full ventilatory support, we try to come down on the support, like minimum FiO2, minimum PEEP. So whatever is so try to let the patient breathe at itself. So synchronized mode will be something which will be helping in it. Okay. Then next will be the pressure support ventilation, and then patient is off ventilator and on put on spontaneous with the TPs trial. If all everything is going in good direction, then you can think about extubation. But again, if you extubate early, the reintubation is associated with very bad prognosis, and it's one of the factor
सब्ज
for,
में जगह थी बंदा सब
it is a factor for increased mortality and morbidity. Okay. So, what is scared hit the iron when it is hot. So, if you try to extubate the patient early, that will be a big problem. Okay. So, whenever there are there are some like the weaning criteria, if we think about it. So, the basic simple, well, the written things will be written in the books. So I will try to give you a concept that when you will try to wean off, when there is no indication to keep the patient on ventilator. This is number one. Number two, the primary disease pathology or the reason for which patient was ventilated is gone. Okay. Now the patient is on minimum support with reference to respiratory system. The patient is not on high inotropes. The acid base balance is good. Electrolytes are good. So now you can think about uh, removing the ventilator. And then it was objectively, these are all subjective things which I have to. So objectively, there will be certain blood gas parameters, there will be certain mechanical parameters. Okay. So can you enumerate the parameters for that? Can anyone know about, remember? It's not written here. Maybe here.
Sir,
Mechanical parameters, if you think.
sir, I have a question. Can we
Yes.
uh, put unweaning or spontaneous breathing trial and followed by extubation if the patient is on minimal inotropic support?
Yes, yes, that's what I'm saying. Minimum. Yes, it's fine.
Okay, sir. Okay, sir. Now you are asking that when we have to wean off,
No, no. Like I have
sir.
told you, the basic disease is gone. There is no reason, minimum
Yes,
support. And now objectively, how we identify. So there are certain blood gases parameter. There are certain mechanical
yes,
parameters. Now it's in front of you on the screen. If you don't are not looking at the screen, you can tell. Okay. So minute ventilation,
sir.
vital capacity,
uh, Yes, sir. Vital capacity is important.
respiratory.
Tidal volume is important. Yes, sir. Respiratory rate is important. And then the negative inspiratory force is important. Like tidal volume, we say that it should be more than 5 ml per kg.
Mhm.
Respiratory rate should be less than 30 or 35 somewhere written. And the vital capacity is more than 10 ml per kg. And inspiratory pressure should be less than -20 or somewhere -30 is also written. Because if we make it opposite to these, then all these become the intubation criteria as well. And of course, sir, the SpO2 and PaO2 PF ratio is also important. And then the acidosis and the ABGs, we think that pH should be more than 7.3 or more than 7.2 somewhere written. PaCO2 should be for 35 to 45, I think.
Mhm.
And this thing, these criteria parameters comes in ventilatory. And of course, we have to check for the GCS. We have to check for the hemodynamics. We have to check that the patient should be on minimal inotropic supports, and the basic pathology has to be settled down. And these all things, I think,
So normally
included in this.
there are different options. You can go directly from SIMV to SIMV plus pressure support to TPs, or you can come down to pressure support and then go to TPs. And then you should be looking at the parameters which will make you go back to
Yes,
the previous setting. So if the respiratory rate is getting high, saturation is going down, heart rate is going down, blood pressure is going on
yes,
extremes, patient is agitated, sweating, delirious, patient is not. So that is a sign that you have to go back. Okay. So
yes,
any sign of
yes,
respiratory, not only respiratory depression, respiratory obstruction, patient is obstructing, or
sir.
so you are feeling that intercostal muscles are, so that will be a sign that the patient is not ready for
Yes, sir.
extubation. Okay.
Yes,
So these are the things which you should be considering. Okay, so you see the same thing which we will discuss. It's written in a different way here. Sedatives and anything which is disturbing the respiratory center, hyperventilation, any metabolic disturbances, especially metabolic alkalosis. Even it can be metabolic acidosis, respiratory alkalosis. Any it can affect, or there is some organic disease which is still not controlled. So, okay, now I will just try to, at the same time, we will just recall something else. Can you tell me how our muscles contract? What is the pathway from the CNS
sir.
up to the our
Respiratory or
muscles? Muscles
skeletal
mean
muscle.
muscles. Yes.
Uh, sir, skeletal muscles contract on the actin and myosin
No, no,
contraction.
no. I'm asking from the brain. From the brain.
Uh, sir, respiratory center actually control it. They are the drive of
You are not
muscle
understanding my
contraction.
question. How the muscle function occur. I'm not talking about respiration only. Just the skeletal muscle, how contraction, how it occurs. Motor
Sir,
center,
is it charge of
CNS
oxidative
motor
phosphorylation?
center, cerebellum, it is controlling the fine movements, then thalamus, and then coming down, descending pathway,
Sir,
motor
yes, sir.
pathways. What are the motor
Yes.
pathways in spinal cord?
Corticospinal tract, uh,
Yes.
uh, uh,
Okay.
they are important. Yes, sir.
Then what
And
happens?
then
Then the peripheral nerves,
uh,
peripheral
peripheral
nerves,
neuromuscular action occur
nerves. Then
at
they are
neuromuscular.
going to the what you say at
Neuromuscular.
neuromuscular junction. Okay. So there, what happens? The action potential comes. There is release of
Yes. Acetylcholine and uh,
acetylcholine. Before that, there is involvement of calcium channels. Okay.
calcium
Then
channel
the
tubules,
acetylcholine is released. It is acting on postsynaptic
neuromuscular.
neuromuscular acetylcholine receptors. Then you started with actin filament. Direct you came here. Now the word
Yes,
actin
sir.
myosin will come. And then
Yes.
contraction occurs. Okay. And then there are
Yes, sir.
certain reflexes. Okay. Blinking reflex or any tendon reflex or any reflex which we say. There are spinal reflexes. There are so the basic concept that why it is important. Now we will try to chalk out all the diseases. If we have a central nervous system problem where the motor centers are destroyed, there will be no movement. Am I right?
Yes, sir.
Because there will be, but at the same time, there may be some spinal reflexes. If your spinal cord is still intact, maybe some spinal reflexes can still occur in brainstem death. Okay. So spinal reflexes still can occur. So this is one thing. Now you come down. So uh, like any like meningitis or encephalitis, it can have effect on the muscular system as well. Then you come down further.
Mm.
What is polio?
Further, the polio and then the myasthenia gravis and GBS,
No,
uh,
polio.
they are.
Just go one by one. So polio, it is affecting. It's a lower motor neuron
Yes, sir.
disease. Okay. So that's why it
Botulism,
causes weakness, and so then comes the Eaton Lambert. It's presynaptic.
eternal.
Okay.
Yes, sir.
Then postsynaptic. Postsynaptic is this
Post-anatomy.
myasthenia gravis. Okay, where the tetanus will
Yes.
fall. Tetanus and muscular dystrophies. Where will they be?
So tetanus actually starts from peripheral, from the area where the microorganism entered.
No, no.
Localize. It says local.
I'm talking. This is the pathogenesis of the disease. How the tetanus, because in tetanus
Sir,
there
it
is
Sir,
rigidity.
inhibits GABA, GABA release,
and
so
central
it's
and
central.
Speak out,
peripheral
please.
and central nervous both are involved.
Just a second. Let Abdurrahman speak, please.
Sir, I was saying that it inhibits the release of inhibitory neurons, uh, so it could be a central pathology.
Pathology, like it is release the control of grandfather is gone. Okay, so the descending inhibitory neurons are gone. So there is rigidity. That's why this opisthotonus and masseter rigidity, okay, rhizus sardonicus, all these occur because of muscle rigidity. Okay. Similarly, these dystrophies, these are directly involving muscles. Okay. So why this is important? That when you are evaluating a patient, you should know at which level of this track there is problem. Okay. And if you just correlate with what we are trying to discuss right now, with reference to ICU, whether there may be an organic problem which is causing neuromuscular weakness or leading to failed weaning, or there is some reversible cause like electrolyte imbalance may be correctable. Okay. And maybe the patient has some genetic predisposition, like this periodic paralysis, which is an exception, which has related to electrolytes, but maybe it is not easily treated. This is one thing. Then any other thing which is correctable. So you will be going towards the correctable thing. And if everything, all the correctable things are there and still there is a critical illness, sorry, this weakness, so that you will label it as a critical illness, polyneuropathy and myopathy. We will just discuss this particular point in detail shortly. Okay. So whenever you are dealing with a patient with failed weaning, all these things are correlated. So they have asked you a question that why they failed winning. So you should be thinking that maybe they are asking that maybe they are dragging you towards any of them. If they are making a question, they can take you with weaning, failed weaning. They can take you to any of the disease, whatever they want to ask, because it will be involving the reversible factors, the neurological problems, the acid-base problem, the electrolyte imbalance, everything. Okay. So that's how you should be thinking about, of course, the physical things like in respiratory system, okay, or and central nervous system, it will be there. So that's how we will be targeting. Okay. So I think weaning, all these things will be there. You can have a look on this. You will go back because it's very simple. If it is failing, you have to go back and continue and try to come back with the like and another something which is part of it is that if the patient is having intubation for prolonged time, maybe tracheostomy will help in weaning. Okay. And then later on the decanalization uh, you can do. So this is the basic theory behind this topic of weaning. So we will just discuss now about this critical illness, myopathy, neuropathy. So it's called as ICU acquired weakness. So there are three different, all of them are like it have similar features, and maybe sometime they coexist. So, but one is critical illness polyneuropathy, one is critical illness myopathy, and one is critical illness neuromyopathy. So they have closed similarities. So if we just read about this polyneuropathy, what happens? Now the body is when the patient is on ventilator or high support for more time, what ultimately there is reduced oxygen and nutrient delivery, and then there is macro circulatory problems like myocardial depression. There is a lot of vasodilation and hypotension, and micro circulatory like endothelial dysfunction and increased cellular adhesion, platelet and coagulation system activation resultant luminal obstruction. So the blood supply is hampered, so which is leading to the pathology, increased permeability, tissue edema, dilatation and shunting. And then ultimately what is happening, that mitochondria function is not good, ATP generation, and then resulting in the this pathology. Okay, a low molecular weight, neurotoxin injury also. So in clean myopathy, this there is reduced muscle membrane excitability, and which is leading to this weakness. Okay, through a combination of depolarization of resting membrane potential and hyperpolarization. When there is hyperpolarization, then the action potential will not occur. Altered sarcoplasmic reticulum function, there is reduced uptake and release of calcium. Like whenever, like if you forget, you can just think that membranes excitability problem or sarcoplasmic reticulum inside the myocyte, because it's the one which is leading to acting myosin contractility. Okay. And then contractile protein decrease. So you can just tell like this: denervation through either pharmacological or structural mechanisms. Okay. So produces an increased expression of corticosteroid receptors within myocyte. This is too much detail, but to just to make you understand. And then ultimately what occur, muscle atrophy starts occurring. Okay. So clinically, if what happens that weakness developing after the onset of critical illness. This is one thing. The weakness being generalized, involving both proximal and distal muscles, symmetrical, flaccid, and generalized, sparing the cranial nerves. Cranial nerves are usually intact. Muscle power assessed by the MRC Council sum score. It's written here. This is muscle power score, flickering, active movement with gravity eliminated, active movement against gravity, and resistance, normal power. So this is how they label it. And then dependence on muscle mechanical ventilation and causes of weakness not related to underlying critical illness have been excluded. So this is how you diagnose. And then ultimately investigation will be that either you find some antibodies like in myasthenia gravis, okay, or some of time you need to do nerve conduction studies or muscle biopsy, okay. Or if you want to see any neurological thing, you might do MRI or CT scan or any vascular um, thing, like if you just want to see. So that's what happened, that you see uh, yes, some blood test also, like this creatinine kinase, some electrolyte imbalance you will find. So this you will for rule out lumbar puncture, neurophysiological assessment with nerve conduction studies, EMGs, okay, MRI, and muscle biopsy, nerve biopsy. So that's how you will diagnose it. What will be the management? There is no specific management, and you will just try to reduce the risk factors. Like glycemic control is one of them. You will try to avoid muscle relaxants. What else you will do? Any specific
Uh,
thing other
uh,
than
uh, sir, weaning, sir, patient should be daily weaning protocol should be followed. Daily weaning.
Physiotherapy and early
physiotherapy?
mobilization.
Like there is no specific rule, okay. So it will be a long term with a lot of things. You will just try to correct everything and what you say, wait and ventilate, okay. So it will be like this. If there is any correctable thing, you will try to correct
Risk
this steroids
management is supporting with focus
support.
on prevention and avoidance of risk factors.
Yes.
It
Okay.
will include early mobilization or early weaning, or physiotherapy, and all the metabolic electrolyte replacements, nutrition balance, strict glycemic control.
Yeah, actually, it will be very difficult to treat if it happens. So that's why prevention is better than cure. So you will try to when the patient is already on the ventilator, you will try to have all the factors which is preventing the VAP, ARDS, sepsis, okay, all the general nursing care, glycemic control, okay, avoidance of muscle relaxant, avoidance of steroids. So these all factors will be. Nutrition should be better, electrolyte should be controlled. So that's how you will be handling. So you see here they have written some individual. Now I have explained to you the basic concept about it. Diagnostic criteria written here. Because if you understand the concept, you can handle the answer. The rest of thing is just cramming stuff. How to the diagnostic criteria exactly. Okay. So just a second. We will just have a few words about tetanus. So tetanus, what is tetanus? Who want to tell?
Yes. Sir, tetanus is the infection which is caused by Clostridium tetani, which is acid fast bacilli. Uh, and it then involves a peripheral nervous system and then central nervous system and can lead to further complications. life-threatening
Okay.
communication.
Okay, anyone can improve this answer? Zishan? They produce
The
two
tetanus is
toxin.
caused by close.
Yes. Yes, speak out of the Rahman.
Okay. So it's caused by Clostridium tetani toxin, which is an obligate anaerobe, which is usually found in soils and feces. It is usually caused by after an injury, or it can be due to after labor, or after basically the spores get entry through any source and they produce two types of toxin, tetanospasmin and tetanolysin.
Tetno, tetrolysine.
Tetanolysin causes uh, local effects and tetanospasmin
It's
enters the
causing
nerve and
neurotoxin. Yes.
yes, it inhibits the release of GABA, which causes its inhibitory, which is inhibitory neurotransmitter, and its effects are reduced. So there is generalized spasticity, rigidity,
So GABA is the
and auto.
inhibitory neurotransmitter. So it will inhibit the GABA pathways. Okay.
Yes.
So which will be releasing GABA. So the inhibitory control will be gone. Okay. So what happened? What else? Another other than this rigidity, another very problematic component of tetanus is one is this
Autonomic dysfunctions.
autonomic dysfunction. Okay, so it will cause swings of blood pressure. It will cause swings of heart rate, blood pressure. Okay, so any noise, anything can stimulate. So in this scenario, you need to relax the muscles. You need to treat. You will like the treatment will be what will be the treatment for tetanus?
It will depend of it will be surgical debridement to stop further entry of toxins,
Okay,
and to neutralize already present toxin we will give uh, human uh, human immunoglobulin toxin. नहीं, tetanus.
neurotoxin. Not.
So
You should be very clear. This question is asked so many
yes,
times. You
human
generally what we give, like there is active toxin, so you need something to immunoglobulins.
immunoglobulin.
IgG.
Human, yes.
Remember one thing, if you are not confident in saying the exact word, be diplomat. If you are forgetting this human test net immunoglobulin, say immunoglobulin. Yeah, Abdur Rahman,
Oh,
something is better than nothing or no?
yes. Yes, sir.
So you
Human
will
tetanus immunoglobulin.
like my brain is still stuck with Safiullah, what he used to say said acid pass vessel. Why you are so much digging your own grave? They can ask you what is it AFB? What is that? If they want examiner want to disturb you, so very easy. Maximum you can say it's a gram negative on anaerobe spore forming. That's it. That's more than enough. Acid fast is something more further more microbiology. We don't remember that much microbiology. Okay, so similarly, if you are not remembering this very difficult name, go for a simple name. Even if you will say immunoglobulin, they will not fail you. Okay, so you will use immunoglobulin. And what else?
Sir, I have a
And
question, sir.
Metabolic
Sir,
treatment
Yeah,
focuses on, sir, neutralizing the toxins, controlling muscle spasm, preventing further toxin production, and which involves hospitalization, wound care, antibiotics, and supportive care, and respiratory support, and
yes.
immunoglobulins.
Okay, yes, Zishan, what you are saying?
sir, shouldn't in the tetanus management, shouldn't we start with the airway breathing and circulation, because there can be respiratory involvement. Patient might have presented with respiratory involvement and cardiovascular involvement
That's
regarding. So
do you
shouldn't we
know?
go with the airway breathing circulation?
Yeah, that's why that actually because you all of you started. So that is why if you remember when I started ICU, why I was stressing on the journal care. Journal care, you can say that in any scenario like this, you always should start with airway breathing circulation, because this is overexcitement all of you do. Like here, my dear friend Safullah, when I asked about the muscle pathway, he directly went into actin myosin. So all of you, when I asked this question without comma full stop, you directly went into the details. You got my point? So you hit the bullseye. Always start with airway breathing circulation. Okay. Airway breathing circulation, general care, and then you can go that there is some specific treatment and there are some general care. So in general care, you should tell these things, okay? Because you say that patient with tetanus might need immediate intubation because the patient is having muscle spasm and may have respiratory failure and cardiac arrest immediately. Okay, so you need to secure the airway, breathing circulation, then you will be avoiding the autonomic reflexes, and then you will go towards the source. If you have a maybe sometime there is no obvious source. Do you know? It can go even from because it can go even through the anything which you even they don't know. So maybe there is no obvious surgical site. Okay. So then you will go for if it is there, you will go and then you go antibiotics for for bacteria. If the toxins are released, you will treat with that one. And even what about immunopheresis has some role?
No, sir.
No, I think yes. No,
Yeah.
any other because any toxins can be can be removed or no. Okay,
Sir,
maybe I
plasma
miss.
exchange,
So this
plasma exchange.
I'm not sure about it. So just anyways, if it is not there, okay, fine. Maybe I'm mistaking it. But you see, like you see, as mentioned here, that respiratory distress patient can have diaphragmatic paralysis and inadequate respiratory muscle contraction immediately. So patient can die. Okay. So then they can ask you about the features. You can tell about the features, but the basic management will be uh, uh, like you mentioned, airway breathing circulation. And also when this another fellow he told about all the stepwise that what you need. Okay, so muscle rigidity, magnesium is being used, baclofen is being used, even dantrolene may be required. Okay, and rest of the supportive treatment which we discuss in detail, all the prevention of VAP, prevention of bundles, sedation break, posture change, everything will be there. Okay, nutrition, fast hug in the bed, all thing will be there. Okay, and then actually the difficult part which I always forget about the immunization. One is active immunization and one is passive immunization. So what we do, for example, if we had a fall outside, what we take this ATS, what is it? It is passive or active? Anti-tetanus serum is passive or active?
active, sir. Active, sir.
Active. So what is passive? That TT, tetanus toxide is passive because there are two different things. Am I right? One is tetanus toxide, what we take in the I think I have
So tetanus toxide is also is active. Immunoglobulin is, I think, passive, sir.
no,
Tetanus
no, no.
immunoglobulin.
Immunoglobulins is active. Immunoglobulins, you are killing the toxins. Okay. So I'm sorry, I always make a concept, and next time, till the time I am again discussing it, I am again forgetting. So please make sure what is active immunization and what is passive immunization. I'm giving you the question and you find the answer. I think
It's a
tetanus
tetanus
toxide I think
toxide
is passive. Sorry, what are you saying?
Sir, I
Please.
Sir,
just Googled it
tetanus
on.
toxoid is active.
Okay, please, Abdur Rahman, what answer you found?
Sir, immunoglobulins are passive, uh, and active is vaccination.
Vaccination.
Yes,
Which
sir.
vaccination?
Actually,
Sir, any
uh,
sort of vaccination we are getting, it's an active type of immunity, and any antibodies, monoclonal antibodies we are giving to patient, that is passive immunity.
Okay. Anyways, because
Yes, here it is written that active immunity is that which helps body to produce antibodies like vaccine.
okay,
So
okay,
tetanus toxoid is active, or immunoglobulins IgG is passive immunity. Passive immunity, it give antibodies from externally to kill organisms.
okay.
Active is
You
that
are,
will help
you are,
body to produce it.
yes, you are stimulating the body for a response. So that is active immunization. Okay.
yes,
So
sir.
even
Body
then, ATS is also active.
anti-tetanus serum, sir, that could be also because these things produce antibodies and then it protects in long term for years. But the immunoglobulins which we give, those are itself antibodies, and it neutralize the toxins.
Neutralize the toxin.
Uh, yes, sir.
Okay.
It's
Okay.
for
So
short term.
so that, like, again, they will ask you what is tetanus. What is the organism? They can ask you a few questions about the organisms. They can ask you about features. So you can tell about this opisthotonus, masseter muscle rigidity, and this rhizus sardonicus, opisthotonus. Then they will ask you what are the features of this disease, what is the pathophysiology. Then they will ask you that you can because 5 minutes what they will ask. So you have to be very smart, that you should be knowing what questions they can ask you and focus on the main specific questions. So most probably these are the failing points, and then you should know how to give the like specific treatment and generalized treatment. So this is a maximum they can ask you about tetanus. Okay. So you can review this source. So for further, like tetanus neonatorium, uh, this one. Okay. So what is GB syndrome? Here,
The
then
GB syndrome is autoimmune inflammatory demyelinating polyneuropathy in which there is ascending paralysis, areflexia, and potentially respiratory failure can occur, but it is preceded by some respiratory or gastrointestinal infection.
infection. Then there is antibody formation against our body.
And
Uh,
antibodies formed, and then the demyelination occur of the peripheral neurons.
so then they can ask you about these. This is a abbreviation: Aman, Amsan, okay,
Yes, sir.
and
These are the
Miller-Fisher.
subtype.
So you should
AIDP
be,
is also most common.
yes, AIDP, acute inflammatory demyelinating polyradiculoneuropathy. Okay.
Yes, sir.
And then Aman is acute motor axonal neuropathy. You should know a few words about it. What is Aman? What is Amsan? What is Miller-Fisher? Miller-Fisher actually has ataxia, areflexia, and ophthalmoplegia. Okay. And in Aman, the clinical features are like AIDP, but tendon reflexes may be preserved because it's neuropathy. So maybe tendon reflexes will be preserved. And electrophysiological testing may distinguish between other variants as selective motor nerve and axonal involvement is demonstrated. Okay. So uh, it's a clinical diagnosis usually. But in CSF, proteins are high, if I'm not wrong. Okay. And then might be isolate some antibodies, but not necessarily. Then maybe you will find some viral markers. Okay. What else? Uh, Again, the treatment is the same journal treatment. Okay. Same ICU care. You will monitor the patient with the like vital capacity. If it is going down, you might need to. If respiratory muscles are involved, you might need to intubate. Okay. And even these patient, because sometimes there is delayed weaning, so might need tracheostomy. Okay. You see respiratory function test, nerve conduction studies, and differential diagnosis as we discussed before. So metabolic problem, infective problem, uh, and here I think the immunomodulatory is here the plasmapheresis will come, right? Active intravenous
Yes.
immunoglobulin and plasma exchange. Steroids no longer used. Because they used to think that it is immune mediated. So steroids may be helpful, but I think now no, they are not using it. They can ask you how to do plasma exchange. Have you got any idea?
Sir, for that we pass central line, and then there is a separate system for it. When we have to use, we have to calculate it. I think 250 ml. Uh, uh, exact, I am not remembering the how much it is, but we have to use it on alternate days. So 5 or 6 sessions are done
Yes, sir.
through
Yes,
vascular
total
access.
6 sessions,
And
30 ml per kg per session.
Okay.
30 to 40 ml per session, and then anticoagulant is also sometime
Because it will
added
be
in it.
extracorporeal. So there, whenever the extracorporeal circulation will be there, so you need to give anticoagulants, okay, and then you have to replace
Yeah.
with FFPs or human albumin. So it's like that, and all the infections, infectious complications, coagulopathy, it can cause hemodynamic instability. Everything can occur. So and then same it is immunoglobulins, okay. Whenever they are using any immunoglobulin, in anaphylaxis can occur. Okay. So all the rest of the things are the common. So GB syndrome is frequently asked. Either of this topic, GB syndrome, myasthenia gravis, tetanus, they are frequently asked uh, among frequently asked topics. And they have, if you understand the topic, in all, you have to have central nervous system involvement or spinal cord involvement, what level of neuromuscular transmission there is problem, and how to identify. Okay. So in all the problems, you need maybe nerve conduction, CT scan, MRI, electrolytes, lumbar puncture. Okay. So that's how you will handle this question. Mm, Polio patient can
Sir,
come
this
for, yes.
sir, this last viva time they put a long case of only for GB syndrome. I don't know exactly what was the surgery, but the whole long case was on GB syndrome
Hmm.
on first day of viva.
Like, so actually such cases can become easy. Okay. What will be the care in polio patient? Anesthesia consideration in polio.
So general care and then specific care.
Okay.
Uh, depends upon the presentation, depends upon the surgery if it is needed.
Mm-hmm.
Uh, and usually it affects single limb and If it progress, then restrictive lung disease it can present with restrictive type of lung disease. So we have to give care.
Can it cause kyphoscoliosis as well, polio?
Yes, sir. It can present.
Cause muscle
It can
weakness occur.
cause
It can cause
muscle.
this can
Yes,
cause
sir.
this
So
kyphoscoliosis as well.
we have to give braces, physiotherapy to prevent contractures. The surgeries are done by orthopedic surgeons.
No,
And then
actually, question is
we,
that you have a polio patient. Like they can ask you in
sir,
a scenario that you have a patient, known case of polio with some weakness presented for cesarean section.
presented for cesarean section. Okay, sir. Sir, we have to assess and evaluate first the patient. We have to ask history. That since how long she had this polio, and how much it has affect his routine life uh, and any other comorbids or other association with it. Then we have to examine, we have to investigate the general and some specific test we can also do. Well, as far as
Just one thing in the exam, if they are asking about cesarean section, will you have time for all these things?
no, sir, brief history and brief examination we would
Like try to minimize, because your answer should be starting that if it is cesarean section, you have to discuss with the surgeon first. Okay,
yes,
make a
yes,
habit, make a habit of the saying this thing, any surgery, because surgical urgency will define any management. So it will be a good gesture if you say that I will make sure that how much is the urgency of the surgery. Maybe cesarean section, maybe any surgery. So you have to discuss with them. Only then you can have all these things. History exam evaluation, of
yes,
course, you will do, but at that time, simple answer will be that you will document the neurological status, and
yes, sir.
even you can give spinal. There is no absolute contraindication. Okay. And among the GA, which medications you will avoid?
Sir,
Yes, Saksa.
muscle relaxant. Tiva is
Yes.
preferred then if we have to choose. Uh,
Yes, Zishan, you are
if we
saying something?
Yes, sir. Because of denervation of lower motor neurons, succinylcholine can have exaggerated response. So succinylcholine should be
Mediated
avoided, sir.
hyperkalemia. And
Yes, sir.
what about non-depolarizing? I don't think so. There is contraindication to give them.
Yes, sir. I think
You can
non-depolarizing should be fine, sir.
you can use nerve stimulation, okay, neuromuscular stimulation, and you can use cisatracurium. Like it will be a better short acting you can use. Okay. Why you are saying Tiva?
Sir, because there are problems with it, with the neuromuscular, if we give like delayed recovery and things like that. If it is has some central association as well.
Yes.
Like sometimes it presents with some other disordering muscular type disorder as well.
Can polio patient have autonomic problem?
Polio patient, if we say that it is only polio, then I don't think so.
Any other opinion?
Polio patient autonomic neuropathy.
Sorry?
Or autonomic, yes. Polio patient, poliomyelitis has autonomic neuropathy.
I'm just like not clearly picking it up. Maybe it is. I think um, I think whenever there is involvement of nervous
Autonomic
system,
neuropathy.
autonomic neuropathy can be
Autonomic
there.
neuropathy.
Autonomic neuropathy can be there. Yes, Abdurrahman, any idea?
Sir, about autonomic neuropathy, sir. No
Yes.
idea, sir.
So because this is also a question which they can ask you, and because it's not written in book, so you can be in trouble. Its answer is very simple. Any neurological, like uh, one question they can ask, and they have asked some time, is Charcot-Marie-Tooth disease. Okay. Now, Charcot-Marie-Tooth disease is also, you can say, you can, if you don't remember exactly what exactly this such disease is, if you just remember it's a neurological problem, the smart answer will be, you will document the neurological status, okay, and you can proceed with the surgery, okay. You can have, and actually I have Googled it, and there is autonomic dysfunction in polio, okay. So that's what I was thinking, that any neurological problem, then if it is involving nervous system, it can have. So even in TIVA, you can have swings of blood pressure. Even if you give spinal, it can have exaggerated effect. If you are using muscle relaxant, there may be sensitivity. There may be chances of hyperkalemia with succinylcholine. So I think that will be covering. So you can say that in addition to standard 1, standard 2 monitoring, you will have strict monitoring of neuromuscular weakness, neuromuscular status. Okay. You can have
Sir, any
arterial
other
lymph.
special consideration?
Sorry.
That
Is
there
there any
are
other
autonomic digestive
consideration?
problems, and we should take care of aspiration prophylaxis.
As whenever autonomic neuropathy come, the our friend risk of aspiration will come. Okay. So you see, they have written here. Paralytic polio have neurological recovery of at least 15 years, gradual onset of muscle weakness, pain, or other neurological symptoms, fatigue, weakness, muscle pain, respiratory difficulty, cold intolerance, dysphagia. Okay. So dysphagia is, there may be risk of aspiration. Mm, okay. What is myasthenia gravis?
It's an autoimmune disease in which there is antibodies against postsynaptic acetylcholine receptors, and when 70% of receptors are damaged, patient presents with increased muscle weakness, which resolve following rest.
Okay. So I only have objection of this word 70%. You know why you want to make yourself in trouble? And I'm afraid all of you have this strong infatuation of saying these closed-ended sentences. Because I'm not saying that maybe you are right, but for example, if they catch you, you can say that there is a long variability. Maybe it is ophthalmic, or it is involving bulbar muscles or respiratory muscle. So for anesthetist, the involvement of respiratory muscle and bulbar muscle is important, because respiratory muscle, if weakness is there, there may be post-operative ventilation. So you have to make sure the patient does not have decreased vital capacity preoperatively. And another pulmonary risk like COPD or smoking, so it will increase the risk. And then other factors will be disease duration, high dose of pyridostigmine. Okay. So these things will be, and bulbar weakness, they will say any regurg and risk of aspiration, pneumonias. So this is also a risk for you. And the third thing you will say about the different response of mu- uh, muscle relaxants and reversal agents. Okay. So succinylcholine will have resistance, and the non-depolarizing will have sensitivity. Okay. So that's how you can answer this thing. Then they can ask you about ocular and non-ocular. And usually this question, they will be asking you Either they will ask you that myasthenia gravis patient coming for thymectomy or myasthenia gravis patient for other surgery. So you should be knowing what they can ask you about it. A number of times they can ask you about like any other surgery, or they can ask you about thymectomy as well. So if they are asking about thymectomy, so thymectomy involves like they can do it with VATS, they can use it with thoracotomy, even midline or lateral. Okay. So and maybe double lumen tube may be required. So like this is how you will optimize the patient. You will make sure the neuromuscular status is maintained with immunosuppressant or steroids or these pyridoxine means. And also here, also the plasma pheresis will come, immunoglobulins will come or no?
Yes, sir. Here they
Yes,
will
sir.
come.
Pre-optimization period we can use.
So immune modulating treatments, immunoglobulins, plasma exchange, okay, and then thymectomy. So like this is a very simple topic to explain, and you see that's what I have told you. Thymectomy, median sternotomy. So uh, the rest of the answer will be the same, and the same theory which I tell you. I always tell about preoperative optimization, referrals, okay, and all the medications or anything you want to optimize before the surgery. And then when you are telling about intraoperatively, always tell about each and every step. Tell about monitoring, tell about induction agent, tell about muscle relaxant, tell about stress response prevention, tell about aspiration risk, tell about maintenance, tell about analgesia, tell about postoperative outcome. That's what we always have a look here. Uh, what in where it has gone, just a second. So you see, just one. I will show you again, which I show you on a time. So you don't forget that this answer should be the common one, and it is there for any surgery. You will fit it here, and you will see anything extra. Okay. So mm, okay with the topic,
Yes, sir.
emergency. You might need the patient to be on post-operative ICU or HDU may be required. Drugs associated with exacerbation of myasthenia gravis. Aminoglycoside, beta blockers, how? Beta blockers, beta blockers and myasthenia gravis, how? Because they will ask you such questions similarly, okay? Myasthenia gravis in a pregnant patient. Exacerbation of myasthenia are most likely to occur during the first trimester and postpartum period. And antenatal anesthetic assessment should occur, labor analgesia delivery. Low dose mixture of local anesthetic and opioid reduce the requirement of systemic opioids. Minimal motor block. Myasthenia gravis may affect the muscle uterus during the second stage of labor, leading to fatigue and increased need for instrumental delivery. Epidural analgesia can be supplemented with higher concentration of local anesthetic to produce lumbosacral anesthesia without affecting respiratory function. Again, the thing will be that more risk of aspiration. So you see, 1 + 1 will be 3. The pregnancy changes plus myasthenia gravis changes. So it will increase, and the gravity will be increased. Okay. So, and even the transient neonatal myasthenia gravis can be there. So neonates might need an ICU, or you need to have a discussion with the neonatologist. So that is what maximum they will ask you. Mm. And now, for example, if a patient is having any complication like they have here eclamptic. So magnesium you are giving, so it will increase the chances of uh, muscle weakness. Already muscles are weak, so magnesium will also lead to. So you will just mention this thing. Then again in the monitoring, you will say that I will reduce the neuromuscular monitoring. So answers are very simple. You just have to understand what is the important thing in it. Okay. So if you understand this thing, your management will become. And there, what's one thing it's not written, I did not find, but just tell me one thing. If you are using rocuronium, you are avoiding the use of neostigmine and the other medication, and it is complete reversal with rocuronium. If you are using very small dose of rocuronium and then you're reversing with Sogamadex, I think it should also work. I'm not sure it's written here somewhere or not. So if they are enthusiastic to ask you some more detail, then you can, I think you can answer like this. But usually, because it is written, then one tenth dose of atracurium. That's what written in the book. Am I right?
Yes,
Yes,
sir.
sir.
1/10.
Yes, so you can, if you want to make yourself a better answer, you can say that because there is increased sensitivity, you will reduce the dose even up to 110, and you will gradually with the help of neuromuscular monitoring, you will manage the case. Okay, so this is another topic covered. Mm, One of the most irritating topic, this neuromuscular Duchenne Duchenne muscular dystrophy. Uh, one of my very close friend, he was asked this topic in the exam, and he had no idea about it. So he started smiling. So the examiner became very irritated that why you are smiling. He said, I have no idea about this disease. So that's why I'm ready for the failure. Uh, so actually, these dystrophies are very irritating. You see, And you see, that's what I was telling you, that you should, from different articles or different sources, you should just make sure that you know that what are the different steps, different things occur. Okay. So you see, as I told you, that in peripheral neuropathies, even this Charcot-Marie-Tooth disease is pre-junctional, and post-junctional in the muscles, this dystrophies like Duchenne or Becker's or myotonia, this myotonic dystrophy, and because they ask a question even in the some of the helping books, there is a scenario, myotonic dystrophy for dental procedure, something like that. So how will you manage? This is also written. Quiet disorder, prejunctional motor neuron disease, multiple sclerosis, we will also have a look. GB syndrome and peripheral neuropathies as in diabetes mellitus. Junctional myasthenia gravis, Eaton Lambert. And post-junctional inflammatory myopathies and critical illness polyneuropathy neuropathy. Okay. So this is how you will, and again in the when they are diagnosis, it's in a number of time it's a clinical diagnosis, because you will not find any specific thing. In some cases, maybe there is genetic predisposition. Am I right? As in these hereditary. Just a second, please. Few words about these. Inshallah, in 10 15 minutes, we will finish this topic. You see, chronic peripheral neuromuscular denervation. Okay. So they are coming for orthopedic interventions like deformities. So, what will be the concern? Depolarizing neuromuscular blocking agents should be avoided due to denervation of muscle, and can have the or hyperkalemic problems. Friedreich ataxia is an autosomal recessive ataxia. Clinically features skeletal muscle weakness and progressive limb ataxia. Myocardial degeneration frequently occurs. So actually, in all these generally, autonomic problems, neurological problems, muscle weakness, and then sensitivity to neuromuscular blockers, and then involvement of heart. This is journal. If you forget, this is your savior. So even in Duchenne, what is this? Most common childhood muscular dystrophy, X-linked recessive disorder appears in childhood. Another, I will tell you, if you forget,
कॉफी बना
or
रहे
if
हैं
they
आपने
have
खाना नहीं
asked,
खाना
if you have asked, if you have been asked about this topic, don't start with these things. We try to be very simple. If they ask you only, then tell, because these things a number of time you can forget. So if they are asking you, you can start with simple answer, and then if they ask you in detail, then you can try to tell, because maybe if you are start telling this thing and if you tell wrong, it will create a bad impression. Okay, like this is X-linked recessive disorder. Maybe if you forget in exam, you say something else. So rather than saying something wrong, it's better to use only the word which are simple. Okay, so there is progressive wasting and weakness, usually of proximal muscle, fatal by late adolescent from respiratory or cardiac failure. So whatever it will have problems with the either skeletal muscle. So patient will be bed bound or wheelchair bound. So whenever things like that, any skeletal muscle or any weakness, if it is involving the respiratory system, there will be problem in removing the sputum. So chances of pneumonias. So this will be there. And then if it is involving the cardiac muscle, so there cardiomyopathies and heart failure. So it's very simple if you understand this thing. Okay. Mm, contractures, mass scoliosis, restrictive lung function, and cardiac myopathies. Okay. So Becker's also dystrophin protein is only partially absent. In here, it is this dystrophin disorder lack dystrophin, a protein that helps to anchor muscle cells to extra cellular matrix. So again, I'm repeating the simple things again and again, that anything like this come, you will have neurological problem, muscular weakness, in altered response to the neuromuscular blocking agents, autonomic neuropathies leading to swings of blood pressure. So you might need arterial blood pressure monitoring. You might need to avoid muscle relaxants. If and then the cardiovascular involvement is there. So you can have arterial blood pressure monitoring or risk stratification, heart failure medication. These things will be there. Okay. So
Sir, we can also say hypothermia because these patients usually
yes, yes,
hypothermic,
yes.
prone to hypothermia.
Hypothermia also. Okay. So Becker's particular risk during anesthesia, postoperative respiratory, and all have postoperative respiratory failure as well. Cardiac dysfunction related to cardiomyopathies, arrhythmias. Whenever there is cardiomyopathy, either heart failure will occur, arrhythmia will occur, or ischemia will occur. This is only so you can, if you forget what is written especially about it, you can go simply by telling these things. Okay. Mm. Blood loss may be increased due to smooth muscle and platelet dysfunction. Hypotensive anesthesia has been recommended to avoid large blood loss volume. However, hypovolemia should be avoided due to relatively fixed cardiac output. So if you read this word and you try to explore, say by that, if you are doing anything, because the heart is already weak, so you have to be very careful in conducting the anesthesia. Okay, you can make an individualized plan for that patient. So any muscular problem, CK levels can be high. Alkaline phosphatase may be high. Okay. So again, okay. So myotonias. Myotonias, what happened? Even inhalational agents also. Remember one thing, that inhalational agents, they are also having depression in the muscle function. Okay. So this can also exaggerate the problems. Even you see it is Inhalational agents has been implicated in the rhabdomyolysis seen in Duchenne muscular dystrophy. So maybe in these cases you can say about use of IATIVA. Okay, because anything which is exaggerating the muscle weakness or a muscle problem, you can avoid. Okay, so myotonias, the tone is increased by any dystrophic myotonias, including muscle wasting and weakness are seen. This is in contrast to non-dystrophic myotonias, myotonia congenita, and familial periodic paralysis, where the main symptom can be prolonged muscle contraction. Okay, so in myotonic dystrophy, that's a question which is asked with dental procedures in a number of times. Uh, in complete muscle relaxation, especially the inability to let go after a hand grip, muscle wasting, cardiac abnormalities, conduction defects, chondromyopathy, structural deformities, respiratory abnormalities, restrictive lung disease. You see, everything is being repeated. So if you forget, that's a rescue for you. Then all these myotonias and muscular dystrophies, there are so many things which are common. Okay. So factors that may precipitate myotonia must be avoided. One of them will be hypothymia, okay? Shivering, mechanical and electrical stimulation. So increased sensitivity to sedatives, analgesic due to respiratory involvement. So you should be using uh, this one. And here, the depolarizing muscle will produce contractures, okay? Anticholinergic drugs may precipitate contractures due to increased sensitivity to acetylcholine. So you have to avoid muscle relaxants at all. Glucose metabolism may be affected as part of disease, and therefore levels should be monitored perioperatively. Bulbar weakness will risk of aspiration. So bulbar weakness with aspiration, cardiac muscle weakness for cardiomyopathies, and respiratory muscle weakness for postoperative ventilation. Okay. And separately, all of these, if you read, all of these will have almost the same in hyperkalemic periodic paralysis, episodes of flaccid paralysis, okay, and related to hyperkalemia. So perioperative potassium depletion has been recommended with the use of loop diuretics. Any drugs that cause potassium release from cells should be avoided. So again, this one will come. Anything in which electrolyte imbalance is there, you can say ECG is specifically needed. You can see even 5-lead ECG. You can say maybe you are monitoring more strictly. Okay. And strict monitoring of electrolytes. So should ECG monitoring should be continued, and calcium should be available for emergency treatment of hyperkalemic induced weakness. Fasting should be minimized, and glucose containing fluids infused during fasting periods. Hypothermia should be avoided. Okay. Uh, and hypokalemic is opposite. So what happens here? Rare autosomal dominant condition that result in defective calcium channels, and in most cases it's related to mutations. Actually, this is very difficult to remember. That's why if this question is being asked, you can come up with the common things which you can tell, which I am again and again telling. Neuromuscular monitoring, avoidance of neuromuscular blocking agents, careful monitoring of blood pressure with arterial blood pressure monitoring, if possible, cardiac output monitoring, avoiding any factors which can have effect on electrolyte balance. Okay. So anything which is really causing hyperkalemia or hypokalemia should be avoided. And you should immediately monitor and treat accordingly. Perioperative management should be directed towards avoiding drugs that can cause serum potassium shift, including salt and glucose loads, maintaining normothermia, and ensuring serum potassium is kept within the normal range. Okay. Okay. One thing I think here is multiple sclerosis. What is multiple sclerosis? It's a
Sir, it is
condition.
again autoimmune disease of central nervous system in which there is uh, spasticity and optic involvement could be also there sometimes.
Spasticity. I think it's weakness. What spasticity? It's a disease of relapse and remission. That's what word I remember.
Yes, yes. You're right.
You see, relapsing, remitting. So it's an autoimmune disease of central nervous system characterized by chronic inflammation with subsequent demyelination of white matter. Okay. So the disease has four classifications. You can read details, but usually what happens? Visual disturbance, partial blindness, paresthesia or weakness in one of more extremities, in the trunk and or on the side, and actually then when there is muscle wasting, then the contractures are occurring. See, uh, demyelination problem, and so in pregnancy, what happens? It can have relapse. Okay, so mm,
Sir,
steroids.
there is involvement of there is involvement of respiratory and bulbar features. So patient can go into respiratory failure or risk of aspiration in severe stages or in an exacerbation of the disease, sir.
Yes. So anyways, so you what should be your answer if it is coming? If it is an emergency, of course you have to proceed with risk stratification. You will try to avoid as a regional anesthesia, or you can give it. If you want to give it, I
Sir,
think the same answer can cover that you will document the neurological status and you can give. That's what I know. Okay. And if you have time, you will get the opinion of the
neuro.
neurologist. So if any optimization in medications, steroids or immunosuppressant, and then of course these maybe have some teratogenic effects as well. So that's not your job to decide. Okay. And that's that you will say that you will refer the patient to neurologist and they will optimize the medications. So you should be knowing individual immunosuppressant which patient is taking, and our friend IV immunoglobulin will also come. Okay. So again, you see autoimmune disease with good efficacy. So if you don't remember, these things will always be there. And anesthetic and severe, I think you will find the same thing. Uh, See, epidural anesthesia has been theorized to be of less risk than spinal anesthesia because of reduced concentration of local anesthetic. Uh, I think ropivacaine will be better than bupivacaine. What do you think?
Sir, we can use if we can say that we can use adjuncts along with use of adjuncts with
So
local
that to
anesthesia, sir.
reduce the dose of
Dose.
local anesthetic. And again, the same is there. Same point is written here. Okay. Uh, because there is demyelination and again, if you can say that if you want to avoid regional anesthesia, even that you are justified. Okay. That if you have any, if that you can decide according to the patient condition, if the patient has disease is severe, because this is a disease, as we mentioned, the variety is too much. Okay. Recently my one of my niece, unfortunately, during the COVID time, she young, 20 years, young girl, she is bedridden. Okay. And it can be um, as normal and model of in our country, Iman Ali. She is having multiple sclerosis and she is as good as normal. So there is a long variety. So you can say that you can evaluate the patient, and if there is no the patient has a disease control, good compliance with medication, maybe you can just document, discuss with the patient risk versus benefit, and then you can decide whether you have to give G or spinal. So actually, this is a smart answer because it's like not 100% safe if you are giving it, and it's not 100% unsafe. It can be given. So it will you if they are in the exam, if they are asking you a question, you can answer in this way. Okay. But usually these all in all these neurological condition, it's not contraindicated. Absolute contraindication is not there. You know, it's hell of a topic, believe me. You cannot imagine how much stress I am having because, you know, these topics we don't really read every day. So I am trying to make it as simple as I can. But please do read it because any one of them, like from where we started weaning, and then we discuss about all the causes of neurological, electrolyte, acid base, and at each level, if you can read in detail the system from the central nervous system up to neuromuscular junction, what diseases occur. Okay. So if you can chalk out, make a list, and then understand common things, it will be easy for you to answer. Okay, so I will stop here, and tomorrow, inshallah, we will try to have session on and this one poisoning. Okay, so please read about it, and especially you know poisoning. There will be journal principles, then specific antidotes, and then a very dangerous topic which is asked number of times in our exam is snake bite. Okay, so do read about it. So thank you very much.
Thank you, sir.
Okay,
Thank you,
bye
sir.
bye.
Allah.